Welcome to this presentation on tuberculosis. In this presentation, we will discuss diagnosis and treatment of drug-susceptible tuberculosis. Treatment of multi-drug resistant TB will not be discussed here, and also prophylactic treatment of latent TB infection is not discussed in this presentation. We will start out with a patient case. Imagine a 53-year-old man admitted to the hospital during your night shift. He complains of low-grade fever, dyspnea, and hemoptysis. He's a heavy smoker, and periodically he also drinks a lot of alcohol. And it appears he's lost approximately 8 kilos of weight during 2 to 3 months. And during that time, he's experienced night sweats and prolonged cough. You find the following on examining him. He's cachectic. He has a temperature of 37.9 degrees Celsius. You hear crackles on the left lung on auscultation. His oxygen saturation is 95%. You find no enlarged lymph nodes and no other significant objective findings. Now, what differential diagnosis comes to your mind here? You're free to think about that for a little while. And meanwhile, I'll say that the session is about TB, so that would be a decent suggestion. But try to think what other differential diagnosis you could come up with. Could be, for example, pneumonia or lung cancer. It could also be tuberculosis. It could also be abscess or empyema due to the prolonged period of symptoms. Fungal infections or other opportunistic infections could be non-tuberculous mycobacteria, HIV. Now, lung cancer has equal symptoms to TB and to what we saw here. But in most Western countries, lung cancer is much more common than TB, and truly we do often find TB cases in programs for diagnosing lung cancer. Abscess or empyema, severe bacterial infections and complications to pneumonia. These entities are also seen commonly in the same risk groups as TB. And finally, fungal infections can yield equal symptoms and can also be seen in the same at-risk populations as tuberculosis. TB is sometimes considered a disease of the past, but it is truly a very relevant health issue worldwide, with substantial morbidity and mortality on a global scale. In many parts of the world, we see high incidences of TB, and in many countries carried by a high burden of HIV. In China and in India, we see higher absolute number of TB cases carried by a fairly high incidence and very high population numbers. And increasingly, the occurrence of drug-resistant TB is a threat to TB control and an issue of concern. And even in Western Europe, TB is not uncommon amongst certain well-defined high-risk groups, including immigrants from high-incidence countries, but also socially marginalized and homeless people. Now, let's get back to our patient. He's still in the ER. And in the following, we will discuss which examinations to perform, when and how to start treatment for tuberculosis, and whether we should isolate this patient. The diagnostic process for TB includes 3 important steps, including clinical evaluation, radiology, and microbiology. Immunological sampling for a Mycobacterium tuberculosis infection is a slightly different story and will be dealt with separately. The clinical evaluation is important in order to raise the suspicion of TB, which is often an important delay factor in low incidence settings. When diagnosing TB, radiology is a cornerstone. Often the first investigation is a plain chest X-ray, and on chest X-ray, tuberculosis can give rise to infiltrates, often but not always located apically. Within the infiltrates, we can see cavernae. It can be accompanied by pleural effusions in some cases, and on CT, the occurrence of tree and bud phenomena representing mucus stagnation in the bronchial system is a hallmark. In this case, the patient had apical infiltrates and cavitating lesions, which is very typical for lung TB. In order to secure the diagnosis of TB, it's important to do correct and timely sampling for microbiological investigation. Microbiological investigations are never better than the sample material investigated, and it's important to secure relevant sample material for lung TB. That's most often sputum samples, or it could be bronchoalveolar lavage or sometimes ventricular lavage. TB can be detected by a microscopy for acid-fast bacilli, and in some parts of the world, this is the only available test for TB. But do be aware that the sensitivity of the microscopy does not exceed 60%. On the other hand, the degree of microscopy positivity reflects the number of bacilli, and we use the microscopy as a proxy for infectiousness. PCR for Mycobacterium tuberculosis yields an overall sensitivity of 75% or so on. And that's a fairly low sensitivity for a PCR analysis, and it is due to the pausibacillary nature of TB disease. The sensitivity of PCR is highest in microscopy positive samples and can be as low as 60% in microscopy negative samples. Culture for TB on special media remains the golden standard for diagnosing TB and is also necessary for drug resistance testing, even though most laboratories today perform molecular biological testing for resistant genes. The downside of culture is that a negative definite result cannot be communicated until after 8 weeks due to the slow growth of mycobacteria. So ensure relevant sample material, and for lung TB that would be sputum and not saliva. If the patient does not produce expectorate sputum samples, it should be considered to do a bronchoalveolar lavage, and also investigating feces samples with PCR for TB yields fairly high sensitivity for lung TB. If extrapulmonary TB is considered, sampling should be done from sites of suspected infection. Do know your enemy, and do know that TB is a pausibacillary infection, and you should not rule out the diagnosis if the suspicion is high enough, even though the first samples might be negative. Do also know that previous TB can leave dead bacteria, for example, in pulmonary cavities for months and years, and can yield false positive results afterwards. Infection with Mycobacterium tuberculosis can be traced with different strategies to detect an immune response towards the mycobacteria. One way of detecting an immune response to Mycobacterium tuberculosis is by using the tuberculin skin test, which tests for a cellular response to Mycobacterium tuberculosis by placing antigens intradermally and reading out an induration that arises in a few days if there is a response. This test has been used for about a century to detect Mycobacterium tuberculosis infection. Within the last few decades, blood samples to detect cellular response to tuberculosis have been marketed, most notably the quantiferin test. Mycobacterium tuberculosis share antigens with different strains of non-tuberculous mycobacteria, and also with the BCG strain of Mycobacterium bovis that is used in the BCG vaccine against tuberculosis. And because of that, the MANC2 test, or the tuberculin skin test, cross-reacts with the prior BCG vaccination and also with a lot of non-tuberculous mycobacteria. Now, using more specific Mycobacterium tuberculosis antigens, including those termed SZ6 and CFP10, a more specific response towards Mycobacterium tuberculosis can be read out. And that's the advantage of the quantiferin test over the MANC2 test, or the tuberculin skin test. That with these tests we overcome cross-reactivity with especially prior BCG vaccination. While the lack of cross-reactivity with prior BCG vaccination is a true advantage of the quantiferin test and the IGRA tests, the tests do not discriminate between latent TB infection and active TB. And they do also not provide power to predict future progression from latent TB infection to active disease. And therefore, the positive predictive value for active TB in populations with a low incidence of TB from a positive quantiferin test is below 2%. So the interferon gamma release assays, IGRAs, mostly used as a quantiferin test, they detect a cellular response to TB specific antigens. And if we find a positive response, we call it latent TB infection because we know it is associated with a small but persistent risk of reactivating TB. The test does not distinguish between latent TB and active TB infection. The tests are not affected by prior BCG vaccination, contrary to the tuberculin skin test. But apart from this, the test is comparable to the over 100-year-old tuberculin skin test. Back to our patient who's still in the ER. He produces 3 sputum samples, whereof 1 early morning sputum sample. He's still in hospital. Now, which measures of infection hygiene do we need to take? Do we need to place him in isolation? What if he's being dismissed from hospital for our outpatient treatment? Now, let us first take a look at guidelines for isolating patients with suspected TB. In Denmark, TB patients are placed in standard single room under isolation. Now, if there is a presumed risk of multi-drug resistant TB, patients should be placed under a negative pressure ventilation. Now, importantly, isolation can be discontinued in 2 different settings. Firstly, if patients have received 2 weeks of effective chemotherapy, and in that case, if we do not suspect multi-drug resistant TB, or if we consider the patient non-contagious, and traditionally that means 3 consecutive negative sputum smear samples. Now, two negative sputum samples are in practical terms enough to cease isolation. And in a single study, it has also been shown that a single negative PCR can be used to discontinue isolation. And it should be remembered that in-hospital isolation is not without cost for the patient. It's stressful, and we know that it negatively affects patients' mental health. It causes increased healthcare expenses, and it's well documented that it carries a substantially elevated risk of care-related adverse events. So isolation should be used when necessary, but only when necessary. Most cases of TB does not need to be admitted to hospital and can be treated on an outpatient basis. In this situation, patients should be informed to stay in home quarantine for the first 2 weeks of treatment. And when initiating outpatient treatment, you should consider if the patient is unlikely to be compliant, and then consider admitting the patient, and also if there is a high risk of drug toxicity or interaction. And it should also be considered if we suspect a high risk of multi-drug resistance. Now, for the patients we discussed before, we receive results from the laboratory for this patient. The first sample is negative on microscopy for acid-fast bacilli, and the second sample is positive. PCR is positive for Mycobacterium tuberculosis complex. The lab tells us there is no signs of genotypic resistance, so we consider the strain to be drug susceptible. He is placed in respiratory isolation and he started on first-line treatment. What does that mean? Standard treatment for drug susceptible TB includes treatment with 4 drugs for the first 2 months, and then a continuation phase with 2 drugs for another 4 months, giving a treatment duration of 6 months altogether. The treatment is supplemented with vitamin B, and that is because isoniazid can cause neurological side effects that can be somehow prevented by supplementing vitamin B. Be aware that there is a high risk of liver toxicity, and also patients should be informed to react on changes in color vision, and also the treatment should be adjusted according to low body weight. There are several side effects that of side effects is an important obstacle in TB treatment, and important side effects are seen for all the standard drugs used in TB, including neuritis and hepatitis. Rifampicin is a very potent cytochrome P450 inductor, and there are several interactions with this treatment. And importantly, a treatment with ethambutol can lead to opticus neuritis, which is potentially irreversible if ethambutol is not discontinued. Now, owing to your skills and knowledge as a clinician, our patient is diagnosed fast, he recovers after 6 months of standard treatment. Congratulations. Remember that the main obstacles for TB diagnosis and treatment in Western Europe is delayed diagnosis. It's also insufficient sample quality, primarily from sputum samples, and especially if the sample consists mainly saliva and not expectorate sputum. Another obstacle is that in low incidence settings, many of the cases occur in difficult to reach population groups, including homeless people, alcohol addicts, and also immigrant population. And in recent years, and increasingly, occurrence of drug-resistant strains is also an obstacle for treatment of TB, even in Western Europe. So, to sum up, TB is not a rare disease in certain high-risk subpopulations in Western Europe. Remember that. Occurrence of resistant strains is an increasing threat to TB control. Diagnosis of TB includes clinical evaluation, radiology, and microbiological sampling. And correct and timely sampling is a key obstacle in the diagnostic process.